once again, you're all welcome to this unique gathering. I say unique because to us, GSD, this is the first of its kind that will be able to organize this and CPD online. Since the COVID time, we know it's been difficult trying to have in-person gathering. And so most have resorted to the online Zoom lectures, and today is the first of its kind. It has always been our heart's desire to meet with you and then to share ideas, enlighten one another when it comes to dermatology. Believe me, we are all learning, so don't see any one of us as being some peculiar people when it comes to dermatology. We still are learning from one another. And this afternoon, as per the program, we have three distinguished speakers who are going to address us, one on how to be able to pick the earliest cutaneous signs if you have a patient who is suffering from diffuse systemic scleroderma. This is a condition we see in our clinics now and then. Some of us who are in the teaching hospital, sometimes it pains us when you see somebody come with a skin disorder that could have been recognized far earlier at the beginning, and it could have been easier for us to intervene. And yet, the person will tell you, I've been to this place, I've been to that place, and then your heart, why is it that this diagnosis was missed? And even if it was, why is it that it was not even considered trying to refer earlier, perhaps to somebody who could be of help until this later stage? After this forum to say this, that let's try as much as possible where you don't have access. And even these days, because of the internet, if you are in doubt and you have any one of us, our contact or something, you can quickly chip in, please. Do you mind if I share this with you? And then we could just give a lead. I remember just recently, I traveled to UHAS, and before I went, one of my students shared some images with me that was consistent with pemphigus vulgaris. And this patient had been there for days. He had no idea. And yet, they tried to just treating the ulcers. I said, the ulcers will not heal. You have to treat the cause. And luckily, I just wrote something. This is what you have to do if you are not able to refer to a dermatologist. And I was going there to teach. I went and had a look at the patient. They are not even started the treatment yet. I gave them the go ahead. And when I came back and he sent me the images, oh, it was just fantastic. And then scabies. Just yesterday at my clinic, a girl came there. She had moved from clinic to clinic. Sitting in front of me, she couldn't help it. She was just scratching the genital, the hands. I said, how can you live like this? So I've not just lived like this. I've gone to places, but the things they gave me, nobody considered it. Scabies is very, very common. I always tell my students, it's unforgiving to really miss scabies. And this afternoon, we are privileged to have a speaker who threw more light on this. And then when COVID came, we were almost bewildered with another pandemic, and that was going to be smallpox. But lucky, we were able to at least arrest the spread. And this afternoon, we are going to hear something about chickenpox and smallpox. Why should you not miss the diagnosis? At this time, I think we'll just pause and then take the opening remarks from the president of the Ghana Society of Dermatology. I just spoke to her. Unfortunately, she may not be here in person to be with us, but the vice president, I think, is going to take her place. So if Dr. Janet Ayiboy is here, can you act on behalf of GST President, Professor Margaret Latte? Dr. Ayiboy.
I'm here.
Oh, okay,
I'm here and I'm glad to do it.
Thank you. All right, so we are ready for you.
Okay. So the president of the Ghana Society of Dermatology, Professor Margaret Latte, even if she cannot be here, she will be greeted. Very senior colleagues, ladies and gentlemen. A very good afternoon to us all. I am Dr. Janet Ayiboy, Vice President of the Society, and standing in today for the President, who is on official duty. You are all welcome. We are very glad to bring across board a new package on skin conditions, touching general medicine, infectiology, and dermatology itself. As Dr. Ajay mentioned before, we apologize for a long break in our presentations, but we are back on board and we can all expect more CPDs from dermatologists to follow. I'm handing over back to our moderator, Dr. Ajay. Welcome to us all.
Thank you so much, Vice President of Ghana Society of Dermatology, the person of Dr. Janet Ayiboy. All right, so with this introductory remark from the President on her behalf, I think we'll just start with our first lecture. This, as I had said earlier on in my opening introductory remarks, is centered on salt and pepper dyspigmentation, a cutaneous sign for early detection of diffuse systemic scleroderma. And this is going to be delivered by no other person than Dr. Janet Ayiboy. So back to you, Janet, your audience.
Okay, thank you very much. So again, welcome. The title of our CPD is The Skin Unveiled as the Mirror of the Body, and my topic illustrates this title very well because the patients that I'm going to show you, they were all referred for the treatment of vitiligo. And unfortunately, when they left the consultation room, they left with a systemic autoimmune condition. Oh, 1 second, it's not moving. Okay, so I'm going to talk about salt and pepper dyspigmentation, a cutaneous sign for early detection of diffuse systemic scleroderma. My outline, I'm just going to remind us very quickly about pigmentation and about differentials when we see people with hypopigmentation. To then talk about my subject, which is a special kind of dyspigmentation or of hypopigmentation called salt and pepper dyspigmentation. So here, just as a reminder, let me look for my pointer. Here are our melanocytes. Inside the melanocytes, we have melanosomes, the small yellow things, and inside the melanosomes, we produce the melanin. We have melanocytes only in the stratum basale of the epidermis, and the melanosomes are being given up to the keratinocytes, like we can see here. To be able to do this, we need tyrosinase. To activate the tyrosinase, free radicals can activate tyrosinase, but especially UV light can activate tyrosinase. We have different kinds of melanocytes, of melanins that we produce, and depending on the quality of the melanin, eomelanin, pheomelanin, depending on the size and distribution of the melanosomes, we have different skin colors. So what we are interested in today is what happens when something happens with the pigmentation. We can have hyperpigmentation. This is a list of conditions that present with hyperpigmentation, and a longer list is the condition presenting with hypopigmentation. And because there are so many, it is important to have an idea so that after my presentation, you don't diagnose everybody with scleroderma, which is not the case. So all these people suffer from condition of either hypo or hyperpigmentation. And most of these patients, if they are referred to us, the referral letter will either say rash or dyspigmentation. So if we can learn how to differentiate them, we can already save the patient some complications. So I will show you some differentials. Here we have a patient presenting complaint gradual depigmentation from neck to toe. Gradual mean he wasn't born with it. It started at some point. We can still see his chin, the leftover, all the color is gone. It is asymptomatic. This is vitiligo. And this is what the patients that I'm going to talk about today were referred for. So vitiligo is an autoimmune condition. And what happens is that an inflammatory infiltrate destroys the melanocytes themselves. So the cells in which the whole melanogenesis happens are destroyed. And that's why they cannot produce any color anymore. So the management, because it's an autoimmune condition, is immunosuppressive treatment. So we stop the immune system from doing this. But what we should also do is to rule out associated autoimmune condition. Vitiligo, alopecia areata, they are more cosmetics, but you can have these kinds of condition together with other autoimmune condition, and we should look for them. The most common one being the one affecting the thyroid. So if you have to do one test for this patient, you should look for the thyroid to rule out autoimmune condition, hypothyroidism. Here, case number 2, congenital depigmentation affecting the forehead and the frontal scalp. Congenital means this baby is born like this. It is asymptomatic. When we look at the parents, the father had the same thing. So what is this? This is called pibaldism. In vitiligo, the patient is born with melanocytes and the autoimmune process destroys them. That's why the color becomes white. In pibaldism, the patient is born without melanocytes at these places where the depigmentation is visible. So there are no melanocytes. There is no inflammation. It is important to know because often these patients are being treated with steroids, but there's no inflammation. So not only will the patient not improve with the steroids, but you are putting him at risk for complication for no good reason. Then here we see somebody with hypopigmented plaques on the face and the trunk, and on direct questioning, we had localized anhidrosis in this area. So he wasn't sweating there and he was feeling less than when comparing to normal skin. So this one is easy, I think. So this is Hansen disease, completely different from the previous ones that we saw. Then here, recurrent hypopigmented macules, sometimes slightly scaly plaques on the trunk, sometimes on the face. It is asymptomatic. Patient calls it his eczema. He uses triple action creams and it goes away, but then it comes back. This is pityriasis versicolor. Here, the dyspigmentation is caused by azelaic acid that is produced by the pathogen, which is Malassezia 44, which lives in our sebaceous glands. And when he overgrows, he's able to change the skin color. That's why the name pityriasis versicolor. So the treatment will be antifungal. And last but not least, congenital absence of pigmentation, albinism. And I thought last, not last, post-inflammatory hypopigmentation. So this is a patient that we treated for psoriasis. After the treatment, he developed this hypopigmentation. So this is just post-inflammatory hypopigmentation. The color will come back. And presenting complaint, depigmented small macules on the legs, asymptomatic. We see it very often in women after the age of 40 or 50. This is called idiopathic guttate hypomelanosis and is caused by photoaging. Management, sun protection, it doesn't have any complication value. And here, we shouldn't forget to mention hypopigmentation caused by corticosteroids. Sometimes people use corticosteroids for whatever reason, and then they're surprised, and even the doctors who prescribe them are surprised that it causes hypopigmentation. So it does cause hypopigmentation, and many people use them for that effect to bleach their skin. So let's come to the ones that we want to talk about today. Here we have two different patients. They were both referred to me for the treatment of vitiligo. We see depigmented patches with follicular pigmentation. So you have a white patch, and in the middle you have pigmented dots. Both patients have it occipital, on the neck, on the upper back, on the chest, especially on the trunk of the right one. So this is what we called salt and pepper dyspigmentation. So here is the first one, a male Ghanaian, age 27, referred for vitiligo, and the dyspigmentation started 2 years prior to presentation, and we saw the depigmented patches with the follicular pigmentation. So in the middle where the pores are, we see leftover color at the places that you can see. So he came just for the color. But then on further examination and on further questioning, I realized that he had microstomia. He wasn't able to open his mouth more than 4.5 centimeter. This is the size for normal. His face appeared rigid, and I had to ask him, has anybody told you that you look different? And he said, yes, people say that his face becomes narrow. He himself, he couldn't tell because most likely it happened very slowly. Then his hands and his fingers, the skin was hard. He was unable to do a complete fist. And as you can see here, there were some tiny ulceration at the end of his fingertips. On top of his fingers, he had calcinosis. He was saying that sometimes he scraped it off and it comes off like shark. On direct questioning, I asked him about Raynaud because I was thinking about scleroderma. I asked him about GERD symptoms, and he said that the food sometimes comes up. I usually ask people, are you able to eat when lying on the couch? And if the esophageal involvement is severe, they are not able to do that. He was also talking about easy fatigability on direct questioning, and he was having occasional joint pains. So I thought about scleroderma, did the exams, and his spirometry was indicative for lung involvement, and the barium meal showed also abnormalities. His autoimmune parameters were positive for anti-nuclear factor and anti-SAL70 antibodies. Case number 2, 56 years old. He had a 10 months history of this dyspigmentation that we qualify as salt and pepper with severe pruritus, and he was also referred for vitiligo treatment. When I touched his skin was hard. The whole trunk was hard. The dyspigmentation affected his whole trunk and his face. He had sclerodactyly, not visible on this picture, where the fingers become very hard and thin. In the beginning, we see edema, but then with time, they become thin and stiff. The severe pruritus that he told us about, he had symptoms of GERD, no Raynaud. We couldn't do any investigation because the patient couldn't afford it. So both patients were referred for vitiligo treatment, but were at the end diagnosed with systemic scleroderma. No symptoms were initially reported by the patient themselves, neither to me nor to the referring physician. And that makes it so dangerous because they don't know what we want to know. So if we don't think about scleroderma, we will not ask about it because there's nothing much to ask if we have vitiligo in the head. So, I mean, if we think about vitiligo, there are not so many questions that we will ask. We will ask about family history finish. That's why it's so important to think about differential. So what is scleroderma? It's a rare autoimmune connective tissue disease which involves fibrosis of the skin of the subcutaneous tissue, of the muscles, of some organs, and a progressive vascular dysfunction. It can be localized, then we call it morphea. If it's linear, we call it linear scleroderma. Or it can be systemic. When it's systemic, it can be limited, and the limitation is about the organ involvement. It only affects the esophagus and has a better prognosis than when it's diffuse, because the diffuse one can come with multi-organ affection, and especially the lung can be a very negative prognostic factor. So what do we see on the skin? The fibrosis. The easiest thing to see is it starts normally on the hand, so we ask them to do a fist. So usually the skin is too hard to be able to do a fist. But even by touching it, so from the hand you go upwards to the forearm, then we can see it on the face. People are unable to whistle, are unable to frown because the skin is stiff. And like on the second case, the patient, the whole thorax, the whole trunk was stiff. So the sclerodactyly is the fibrosis of the fingers. In the beginning, in the edematous, in the inflammatory phase, they become swollen. But later, when the fibrosis kicks in, they become thin and stiff. Microstomia, as mentioned before, the motility of the esophagus can be affected because of the fibrosis, and it is more difficult for food to go down. And they will suffer of regurgitation, but of all the GERD symptoms too. Then a very common syndrome in most patients, but not in ours, I will come back to that, is Raynaud. We all know what is Raynaud. And then we have the telangiectasia that are not always so well visible on Black skin. So here we have some pictures of the cutaneous manifestation. So this is another patient. I asked her to open her mouth as big as possible. By the way, in Europe, because people are asked to go to the dentist every year for preventive medicine, there's the dentist who often discovers that there's something wrong because they are unable to open their mouth big enough for him to do his job. So this is the same lady. So she had scleroderma for years, and the multiple ulceration that she had led to auto-amputation of her distal fingers. We see the sclerodactyly, we see the ulcerations, anemia because you are unable to move your face as you wish to, and calcinosis cutis. I have put the dyspigmentation into brackets because it's not part of the common signs. So if you Google scleroderma now, you will not find it. You have to add salt and pepper dyspigmentation and scleroderma before you will find it, because it's a common sign in people with skin of color, Africans, Indians. So these are the papers that are talking about it. So here, just a reminder of the systemic scleroderma, which organs can be affected. So the gastrointestinal tract is the number one. And this is also the one that is affected in the limited disease. But the kidneys can be affected, the lungs, the heart. And when we have severe organ involvement, the patient would battle with renal crisis, cardiomyopathy, pericarditis, arrhythmia, pulmonary fibrosis, and malabsorption. There is the classification criteria. We will share our presentations later, and you can go through it if you are interested. So the prognosis for the patient depends on which organ is affected. I mean, it's bad enough that you can't move your face or your hands, but what makes it really severe is the organ involvement. Worst case scenario for the esophagus involvement will be the inability to eat solid food. But when it attacks your lung or your heart or your kidney, that will reduce drastically the survival rate. And that's why it's important to diagnose the condition before you have severe involvement of lung, heart, or kidneys. So many studies have been made to find out what could be a negative prognostic factor. What should we use to say this patient is at an extra risk to develop the severe form of scleroderma and where we should be more aggressive in the treatment or in the reviews. So here is one study that has been made, and they found in Johns Hopkins University that telangiectasia might be a clinical marker for more widespread microvascular disease in scleroderma. Unfortunately, the telangiectasia are not very well visible. Here, one of the pictures, let me come on this lady, we could see some. So it's not too nicely visible here because of the mouth opening, but she had some few telangiectasia visible, but most of the time we don't see them because of the color of the skin. So the question that we ask ourselves is, what sign can we use in Ghana and in other African countries, especially where for many patients it's very expensive to do all the testing, even if you think about it. And so the cutaneous manifestation that are visible and where you don't need any test become very important, a very important diagnostic tool. So the question was, is there a sign or can we use salt and pepper dyspigmentation as a marker of organ involvement? I am working in 37 military hospital, so I use my hospital to check for the patient that I have seen in the past 5 years and to see if they have anything in common as cutaneous sign. So here are the 10 patients that I saw. 4 of them had morphea, which is a localized form of scleroderma, and the other 6 had systemic scleroderma. So I checked for their signs, and they all have salt and pepper dyspigmentation. 2 had other form of dyspigmentation, sclerosis, so fibrosis of the skin was visible in all of them. So none of this patient with salt and pepper dyspigmentation didn't have scleroderma. None complained about Raynaud, although 3 of them presented with digital ulcers. So Raynaud is when upon contact, when you come in contact with cold, you have constriction of the blood vessels with a typical change of colors. So we don't see that a lot in African patients, and I will show you other studies which confirm that, but we still see the digital ulcers. So one possibility that the patient doesn't complain about it is it's not cold enough for him to feel it, but the vascular component is still visible because half of them had digital ulcer. So 4 of them, of the 6 patients, had microstomia, 3 had involvement of the gastrointestinal tract, 2 of the lungs, 2 of the joints, and 3 had positive antibodies, although we must say that not all of them were able to do it. That's why I didn't put negative here, because they were not negative, they were just not done because too expensive. So the most common finding was the salt and pepper dyspigmentation. It was found in all our patients, and Raynaud, which is normally the most common sign, wasn't found in ours. So here you have 4 of the 6 patients with their form of salt and pepper dyspigmentation. Most of the time, the chest and the neck are affected. So what is this salt and pepper dyspigmentation? It's a vitiligo-like depigmentation with retention of pigment at the follicular stage. So you have the white spots, but where the follicles are, where the pores are, you have a retention of color. It is considered an uncommon cutaneous finding in general, but when we look at publication from African countries and from India, it turns into a common sign. And it is considered an early sign of not only diffuse systemic scleroderma, but as we are going to see, also a sign of severe organ involvement. So here, the question is it as uncommon? So here we have New Zealand, France, and the US, and they talk about between 3 to 25% of their patients had salt and pepper dyspigmentation. But when we come to India, where people are not white, they said 94%, and they considered it as an early diagnostic tool. Here we have publications from Africa, where Mali reports 88% in the 35 patients that they wrote on. Senegal, 70%. Nigeria didn't mention number, but said commonest sign. In Togo, it was 100% from the 21 patient. Ivory Coast, 63. And I wrote Ghana because we are in Ghana, but I'm just talking about the patient that I have in 37. And maybe several hospitals, we should come together to see what are numbers for Ghana in general. So the associated findings were lungs, 45% for the people in Mali, and my 3 patient over 6, we had 33%. So, and here another study which looked at 17 countries of the sub-Saharan continent, and they came up with salt and pepper was a common sign and telangiectasia was uncommon. And we agree with that. So the histopathology and the explanation, how does it come, is unclear. One idea was that the fibrosis of the skin acts as a Koebner phenomenon, as we see it in vitiligo, in lichen planus, and in psoriasis. Koebner phenomenon means trauma causes new lesions in skin that was previously unaffected. So this was one idea, that the fibrosis causes the hypopigmentation, but then there were studies that showed that there are patients with scleroderma, with systemic scleroderma, with the antibodies, with the salt and pepper, but they didn't have scleroderma at the affected parts where the dyspigmentation was. So the question needs still to be answered. So what we want to go home with today is that the presence of salt and pepper dyspigmentation should raise the suspicion of an association with systemic scleroderma. Especially in patients of African descent, it can be useful as an early diagnostic tool, and we should suspect pulmonal involvement. Thank you. This is what I wanted to share with you today.
Oh, thank you so much, Dr. Janet Ayiboy. I think together with my listeners, we can go out there. We are not craving for patients to come to our
Yes.
consulting rooms, but then should we find anyone coming with such a discoloration, as you had pointed out, in vitiligo, you have just a diffuse pigmentary loss. But in this salt and pepper, you have preserved areas of color that corresponds to the hair follicles. So this, I don't think, should pose any difficulty to us if we go and find patients. So on this note, I think according to the program, it's time for questions and answers. So if anybody has any question for our presenter, this is the opportunity for you to voice out. And so we are waiting for any questions and answers from the participants.
And you can also text them, and I can answer them on the chat.
Great. All right, so if you have any question, you can, okay, I've seen one hand up. Let me see if we can find out.
So let me read one of the questions that I can see, and then the others I will answer them in writing. So hello, please, if you find a patient with salt and pepper at a district hospital, what initial steps are you to take? So first of all, if you have the suspicion, if you are sure it's salt and pepper, look for signs of scleroderma. Touch the skin, touch his hands, ask him to make a fist, touch his arm, touch the chest, ask him to open his mouth, ask him to whistle, ask him to frown. All this will be signs that will reinforce your suspicion. Then you ask them about problems with the esophagus. Are they able to eat any kind of food in any position? Does the food come up? Do they have heartburns? Do they have difficulty breathing? Can they run after a bus? And questions like that. Then, so all this will confirm your suspicion. So any autoimmune condition will come with a raised ESR. So you can do the ESR, and maybe you can do an anti-nuclear factor. So there are several autoantibodies specific to scleroderma. The one involving the lungs is the one I talked about before, the anti-SAL-17s, but there are others. So to do everything is expensive. If we don't have problems with money, do at least the anti-nuclear factor and the ESR. So if both are positive, then you have your diagnosis, and then either you are able to refer to a hospital where scleroderma can be treated, and we treat it with immunosuppressive drugs. I don't know how we are going to do it, but I have the presentation on as a PDF, and I've added the treatment at the end of the PDF. I didn't want to talk about everything because of the time limits. So we use corticosteroids, we use Celcept, which is mycophenolate and mofetil. This is the most effective one for the lung involvement, but also for the salt and pepper dyspigmentation. But it will be, if possible, you will refer to a place where the treatment can be initiated, and then you can continue it at district level. Okay, so if other questions are coming, I will answer in typing, and I think we can continue with the program.
All right. So once again, thank you, Dr. Janet Ayiboy, for that remarkable presentation and to enlighten us. And as I said, I know now many of us are itching to go out to our consulting rooms and find any of these ones pass by. This time, we won't miss it. We'll be able to remember what you shared with us. Okay, so if you agree that yes, the rest of the questions, of course, addressed to her, she can answer it personally by typing. Then perhaps we can take the next lecture. And the next talk is about scabies, which I said, indeed, it is common, but sad to say that many colleagues miss the diagnosis. And it's my heart's desire that by the time we are done with this talk, which is going to be delivered by Dr. Bridget Gogo Darko, we will not miss scabies. And at least we will help our patients be delivered from this intractable itch, which cannot be controlled, no matter where you find yourself. Scabies has no respect for where you find yourself. You will scratch. And so we'll just welcome our next speaker, Dr. Bridget Gogo Darko, if she's ready to share her slides with us. Gogo. Bridget, are you there?
Yes, I'm here. Can you hear me?
Thank you. Thank you. We can.
Thank you very much, Dr. Martin Ejay. And thank you, Janet, for such a beautiful presentation. now. Let me see. Okay. Can you see my slides, please?
Yes, we can.
All right. Thank you very much. And I'm Dr. Bridget Gogodako from the Elmazo Skin Consult. And to continue on our topic, the skin unveiled as the mirror of the body, I am taking the infectiology aspect, talking about scabies, common but often misdiagnosed. As Dr. Ajay said, it's rather unfortunate that we find cases getting to us very late in the course of the disease. So this is the outline, an overview, clinical presentation, pearls for diagnosis, reasons why we shouldn't miss diagnosis going forward, and also differential diagnosis and management. So, sorry. Scabies is a parasitic infestation, which we all know, caused by the host-specific mite Sarcoptes scabiei variety homines. And the female mite burrows under the upper layer of the skin, so they stay in the epidermis to lay their eggs. And this results in the intense, intractable itch and rash that patients experience. It is also known as the 7-year itch, because without treatment, it can go on and on and on. In our local parlance, we have some calling it driba, nkrosa, and all other names. It is one of the commonest dermatological conditions, and so it's rather unfortunate that it is often misdiagnosed. When I was in LECMA, scabies will always come top or second to all dermatophytosis. So when we put all dermatophytes for the month together, scabies would usually top this or come second to that. It is of global interest and burden. It is believed that at every point in time, globally, there are about 200 million people infested by scabies, and annually 400 million people. As I said earlier, global public health problem. And let us note, it affects all ages, races, and socio-economic groups. It is no respecter of persons. And so, yes, it is more common in lower income regions and countries, but we should always have a high index of suspicion, regardless of the socio-economic standing of the person. And LECMA, the clients I saw there were across, so it wasn't limited to the Teshi region, from university professors to expatriates. So let's always have a high index of suspicion. In 2017, WHO added scabies to the neglected tropical diseases portfolio. Though very easy to treat, scabies remains common due to delayed access to healthcare. Most of the time, people attribute it to spiritual reasons, because you are itching, you don't understand at every point in time, you are itching, and you think it's a way to disgrace you, or it's somebody, for lack of a better word, doing you. And so they go through all routes, the herbalists, the spiritualists, before they get to the healthcare sector. And unfortunately, when they come to our consulting rooms, they are often misdiagnosed, or inadequate treatment of the patients or their contacts, and also improper environmental control measures. All these attribute to the reasons why scabies is still common. And so if we all come together to fight this battle, it's an easy battle to win. Here we see Africa and West Africa in red, skin neglected tropical diseases 2017 to 2021. Ghana 5+ conditions showing in red, including scabies. This research was done by Iranian Red Crescent Medical Crescent, and it was published in April 2024 in the Iranian Red Crescent Medical Journal, and looking at scabies in high school students in Accra. And the prevalence was 10.3% in general. Interestingly, in the suburban regions, it was 3.7%. And then 19.4% in the urban areas of Accra. And so, as I said, regardless of the socio-economic background of the person, when we look at the pearls of diagnosis, we should still have an index of suspicion very high. Scabies is transmitted by prolonged direct skin-to-skin contact. So there must be a minimum of 20 minutes for the mite to migrate from the skin of an infested person to another. And it is therefore also considered as a sexually transmitted disease. Common scabies, that is scabies which is not the crusted type, rarely is transmitted by infested fomites, though this can happen. And itching would usually start before the rashes, and it would start 4 to 6 weeks after infestation. And we'll see the reason why. And this itch is due to the allergic response of the host. So you might have people in the same household and their degree of itching might be different. It doesn't mean that all of them are not infested, but your response, allergic response, will determine the quantum of your reaction. So here we see the mite. Here the female mite with eggs surrounding it. And then, the male smaller than the female. So this is how the mites look like. And history. History is very, very important. And in taking the history, the patient is likely to tell you of an intractable pruritus, intractable itch. They cannot do anything about it. And this itch is usually worst at night. And we'll see the classic distribution. So the distribution of the lesions is very important. And it comes under history, again, because you ask for places you can't see, especially the genitals in males and the areola in females. Let's note that usually if you are of the opposite gender, when you ask these questions, they are likely to tell you, oh, I don't have it on my genitals. Oh, I don't itch there. But please examine the place. Look, otherwise you will miss it. So distribution of lesions, and then symptoms of close contacts, very, very important. This can be family members, friends in the classroom, friends at work, people we deal closely with, that we come to skin-to-skin contact with. The duration of the itch is also very important. As I mentioned earlier, it's also known as the 7-year itch. So you can just itch if it is not managed. Clinical presentation. In geriatric patients, you are likely to see just excoriations at the back. So no primary lesions visible, just excoriations. In infants and small children, the palms and soles are places you should look out for Barrett's. And then in the adults, there's a typical distribution of 1 to 3 millimeter erythematous papules or vesicles. And this is a classic pathognomonic sign in scabies. So with a little stretch of imagination, I think you can see this bara here. So it's serpentinous, is raised, and it's usually gray or erythematous. So look out for barres in the lesions that are presented to you. And the bara is as a result of the female mite creating tunnels in the stratum corneum to lay her eggs. And in the adults, presentations can just be papules, not just adults. In everyone, presentations can just be papules, vesicles, nodules, or blisters, or just excoriations. The classic distribution in adults we'll see soon, and then in the elderly, infants, and immunosuppressed, it can be just generalized or widespread. So let's look at this cycle of Hebra and let's not forget it. So if a client comes to you with lesions or pruritus and then lesions of any kind in the axillae, the areola in females, the flexure of the elbow, the genitals in males, the wrist, and then the hand, please have a high index of suspicion for scabies. And in the hand, we have the web spaces of the fingers and the flexures of the wrist, the elbow, the belt line, feet in babies, and as I said, scrotum, the penile area, and then the areola in women is very, very important. And the mites like these areas because it's warm and moist. And so you find the mites there. Now let's look at some pictures. So you find the feet of this baby and you can see crusting here. We'll talk about that. And then when you come here, you can see the, sorry, it looks like my pointer is the lesions in the interdigital spaces, the wrist, the elbows. So they are really non-specific, but the distribution should lead you to your diagnosis of scabies. The genitals in male, these nodules should not be missed. When you see these nodules, you should think scabies. The buttocks and umbilicus, and this child. So you can see how the bara has turned into blisters. And when you look, okay, here on the left hand, you see this bara extending onto the dorsum of the finger. And then on the right hand, you see the barres as well. This diagnosis should not be missed. And here again, you see the bara. Even here, you can see a bara forming. Usually in common scabies, and that's non-crusted, there are about 10 to 15 mites on the body at a time, and yet they can be very, very uncomfortable for the person. In babies, it can be generalized, so from the scalp to the soles of the feet, and this should not be missed. When you have redness, pus, or crust associated with the scabies, then it's likely there's a complication of secondary bacterial infection. Impetigo is very much associated with scabies, leading to abscesses and sepsis and invasive infections by Staph aureus and Strep pyogenes, and the strep infection may lead to kidney diseases and rheumatic heart disease. And so we should not take scabies lightly, because there can be significant morbidity associated with it. This is crusted scabies, and it's usually in immunocompromised patients and elderly, and this has loads and loads of mites, and so they shed mites and infect mostly by fomite infestation. Pearls of diagnosis. Let's look at the 2020 International Alliance for the Control of Scabies consensus criteria for the diagnosis of scabies. So it's in 3 parts: A, confirmed scabies; B, clinical scabies; and then C, suspected scabies. So for confirmed scabies, there must be at least one of these present: the mite, eggs, or feces on light microscopy of skin samples. So when samples are scraped, there should be mites or eggs or the feces visible under the microscope. And also with high-powered imaging devices or dermoscopy. But you realize that this confirmed scabies would be usually when we send clients to the lab, but we can diagnose clinically in our consulting room, and it is enough to treat the case. And this should be at least one bara, at least one of these. And this is when you see barres, once you see scabies barres, it is enough to make a clinical scabies diagnosis. Or typical lesions affecting the male genitalia. So I showed you the nodules. Unfortunately, I didn't have a picture on the scrotum, but it looks similar. So you just see nodules on the scrotum, and this should not be missed. So for any male that comes to you with an itch that is worse at night, please request to examine the genital area. Typical lesions in a typical distribution. So we saw the distribution, the circle of Hebra. So you have the typical distribution, and then 2 history features, which is H or a positive contact history. So you need these two to make a clinical diagnosis of scabies. And the C, suspected scabies diagnosis: typical lesions in a typical distribution and 1 history feature. So you can diagnose, you can suspect scabies and make a suspected diagnosis. Atypical lesions or atypical distributions and 2 history features. Most of the times, by the time they get to us, as I was saying, they might have done so many things. And so the lesions might not be typical, but with the atypical lesions and 2 of the history features, which is the age and then the positive contact history, we can make a diagnosis of scabies. Differential diagnosis. So with the bara, the serpiginous nature, our first will be cutaneous larva migrans, especially when they occur on the palms, or as we saw it on the palms or soles. But you are not expecting to see cutaneous larva migrans in the scabies specific distribution areas. It could just be arthropod bites from any insects, and this hydrotic eczema, the palms and soles, and then the volar aspects, and then papular urticaria, and our good old syphilis, which is the great imitator. And the differential diagnosis, this is not exhaustive at all. They are limitless. But for the sake of this presentation, I'm picking these. Now, how do we manage? Management must include not only our primary or index case, but all close contacts. And we must let the clients know that as they start the treatment, with the dying of the mites, they might experience a worsening of their symptoms. It's important to let them know so that they expect it. Should it happen, they are not taken aback. We are also supposed to let them know that the itch can outlast the infestation. So they might be cured, but the itch will take some time to resolve. And then cleaning of fomites, very important, especially encrusted scabies. And this is washing in hot water. Usually would advise that it's soaked in boiled water or very hot water. And then when it's cool enough to wash, it is washed and dried in direct sunlight. Or if in a washing machine, it must be washed at 60 degrees or above. And also seal non-washable items in plastic bags for a week, because it is known that the mite survives off the body for 2 to 3 days, and beyond that, they cannot survive. And then clean the room. Specific treatment. We can use topical or oral scabicides. For topicals, we have 5% permethrin cream, 0.5% malathion in aqueous base, 10 to 25% benzyl benzoate, which is very cheap and available, 5 to 10% sulfur ointment, and then the ivermectin for oral treatment. And we also need to manage the pruritus and also secondary bacterial infections, if any. For permethrin 5% cream, applied over the whole body, including the face and scalp in infants. It should be left on for 8 to 12 hours. And so usually applied at night after a warm bath, and then it is washed off the following day. And reapplication a week later. And this is important because the scabicides that we are using would kill the mites, but not the eggs. So any eggs which hatch after the mites are dead should also be killed. Benzyl benzoate. So on the market, it's usually the 25% benzyl benzoate available. And this is diluted in different parts to the concentrations for these age groups, and then the contact times. And usually we say after a warm bath, you apply. So for children, 2 to 12 years, and then adults. 24, you apply, and then the following morning you don't bath, you reapply. You bath the following evening, and then you apply. Following morning, you don't bath, you reapply, and then in the evening when you bath, that is it. And so that is the repeated 24 hours application. But it can also be applied after 10 minutes of the drying of the first application. 5 to 10% sulfur ointment, 6% preferred. And this is safe in children below 2 months and pregnant women. However, because it is messy, malodorous, and can stain clothing, compliance can be low. And so if we have to use it, we need to really educate the clients as to what to expect and why they must keep at it. And so this must be used if patients cannot tolerate permethrin, benzyl benzoate, or ivermectin. So ivermectin, I'm happy to tell all of us, it's available in Ghana as a program medication. And so usually our disease control officers, those of us in the districts, our disease control officers have it, and it is free because it's used in this country for onchocerciasis and strongyloides, so for mass drug administration. It is, however, contraindicated in patients with allergic sensitization or nervous system disorders, pregnant women or women breastfeeding, and then children younger than 5 years or less than 15 kilos. And the dose is 200 microgram per kilo body weight start, and also repeated after 1 week to take care of the eggs that hatch later. It's available in 3 and 6 milligram tablets on the market now for sale, but usually the program one comes in 3 milligram tablets. So this is a weight dose guide to help you manage, and it's important to keep it on you. Managing the pruritus, any antihistamine of your choice. And for antibacterial creams, purocin can be used for the secondary bacterial infection if it is mild, or oral antibiotics if it is severe. The burden of scabies cannot be overemphasized. The stigmatization, as Dr. J said, it does not know where you are or what you are doing. It can itch anywhere at any time. And so stigmatization, social exclusion, and this is the reason why people think that somebody is doing them. And so we also need to educate our groups, whether our church groups or our communities, so they understand that it is not spiritual. It's a physical disease that can be managed and cured. There are usually outbreaks in certain areas, and this also they think that is a curse on the neighborhood or the community. There's lack of sleep due to this intractable itch. And even when the patient is awake during the day, loss of concentration. And this would lead to absenteeism from school and work, and also lead to reduced productivity. And so the burden is enormous, a very easily treatable condition. So colleagues, let's put all hands on deck and make sure no scabies case goes beyond us undiagnosed. Thank you very much.
Thank you so much, Dr. Bridget Gogo Dakon. I like the last bit that you said, where sometimes patients think somebody is doing them. I think after hearing this renowned talk from you about scabies, clinicians who were doing our patients are missing a diagnosis. I know we will cease from doing them, and now you dare not cross our path with itch that is worse at night, with these lesions at the classic site, and then other people living with you may also complain of the itch. We will not miss scabies. We thank you so much, Dr. Bridget Gogo Dakon. So as per our chat and our program, it's time for questions and answers. So if you have any question, you can flip through, and then that will be picked up for Dr. Gogo. All right. Okay, I don't know, Bridget, if you have it, but I have here a question from Barbara Sari. What influences the use of topical or oral medications for the treatment of scabies? What influences the use of, either you are going to use topical or you are going to go for oral treatment when somebody has scabies?
Okay, thank you very much, Dr. Asari. For me, my personal experience, I think if you have access to ivermectin, especially the program drug, which is free, use it if the contraindications does not affect the client, because compliance is very high, and a start dose. So sometimes the drug is in front of you, so you give the start dose in your consulting room, and then you give the other one to the client. Next week, take it again, same day. So it's very easy. But then when it's contraindicated or in young children, you tend to use the topicals. So information as to what to use is really what is available to you, and the contraindications. So compliance to ivermectin is very high.
Great. There's one too from Sandra Nate. Sandra says, please, we have benzyl benzoate cream available. Would you share with us how that should be used? Benzyl benzoate cream, not the lotion, for example. How should that be used?
Okay, so I think it would depend on the percentage of benzyl benzoate in that preparation, in the cream. So if we saw the percentages that should be used in the different age groups, so if it falls within a percentage of your patients, it can be used, and it should be used in the same application mode as the solution. So what will be limiting here is you cannot dilute to a solution that suits your client if the concentration is not what your client needs.
Great. There are more questions coming. This from Na Mele Doti Ahel. Where ivermectin is contraindicated, is there room to use albendazole with the creams?
Albendazole has been mentioned as a possible method, but it's not been confirmed by WHO as these drugs I've mentioned. But as you are doing topicals, you do not need to do systemic. So you don't need ivermectin if you decide to do topicals. The topicals in themselves are enough to eradicate scabies. So you don't need to add albendazole if your client or patient can be managed with any of the topicals.
Great. Thank you. We have this from Emanuela Asante. She says, I didn't hear you talk about permethrin soap. Is it mandatory to use it all the time in patients with scabies? Permethrin soap, is it a must?
It is not a must. It is not a must. It can be used. I didn't see it in the literature, and so I would imagine that it would help in the shedding of the fomites, but if you don't use it, it wouldn't hurt anything. Just the applications of the topicals, the way mentioned, would do the work.
Okay, thank you.
I don't know if any colleagues here have experience with the permethrin soap that they would want to share.
Not personally.
I think
don't
it
know
cannot
about it.
replace a real treatment.
Yeah.
Oh, yes.
And it's not needed.
Great. Thank you. This is from Nameli. Will you recommend periodic prophylaxis for people from areas prone to scabies? And if so, how often is it quarterly or yearly? So any place where the people there from time to time, it looks like they're susceptible to developing scabies. Is this something you recommend?
So looking at the literature, the neglected tropical diseases machinery is supposed to look at these areas and do mass drug administrations there as they are doing for onco and strongyloides. So this is something WHO is recommending to help curb the menace of scabies. And so I'm hoping that from now to 2030, as their framework says, we should see drastic reduction in scabies cases because of the mass drug administrations that will go on. And so for those of us in the districts, I think it's important to have a high index. It's important to take social history. So to know the schools or the workplaces of your clients, to know the neighborhood they come from, so that if you see something too often coming from a particular area, you can alert your disease control people to go there. The daycare centers are noted for spread because the children are made to sleep on mats together during their rest time and all that. So I think we should be on a lookout, especially in the districts, and then help by using our disease control people. And let me say this, I forgot to add, sometimes in babies, the infestations are from the nannies. So you find mother and father okay, but then the baby has scabies. And then when you ask, you find out it's from the nannies. And so when people are talking about the household, sometimes they neglect the back office workers. And so we need to probe for that.
Great. Let's take this one from Yosin Prince Etonam. Please, I want to know, can children have co-infections of cluster scabies and dandruff? If so, how will you be able to differentiate between them, and what will be the approach to the management? Can a child have both cluster scabies and dandruff?
I think I would say yes, but I also can see where the question is coming from. And in clustered scabies, it will not be restricted to the scalp. So if you have it restricted to the scalp, you have to think beyond scabies. So yes, as we were taught, it can occur, but the if I understand where the question is coming from, then I would say that it might be a case of maybe seborrheic dermatitis than crusted scabies.
Okay, good. We have this from Giorgio Fori. Well, she says, which topical agent would you recommend for the treatment of scabies? I guess this was mentioned.
Which topical
agent would you recommend for the treatment of scabies?
Oh, okay, maybe the person joined late.
Yeah, I guess so.
We mentioned that you can use 6% sulfur, which is the preferred sulfur concentration. You can use 5% permethrin cream, and then you can use benzyl benzoate in the age-appropriate concentrations.
Okay.
And there's also, I don't have experience with that. I don't know whether any of the colleagues have experience with the, what do you call it? The 0.5% malathion in aqueous-based solution.
Well, okay. We'll take this one from Joyce Adomako. He said this is just a comment. So he's just thanking you, Bridget, that I'm very happy this presentation has been of great help to me because he's confessing that he missed one diagnosis, but now he's enlightened. And I know, as I said, now scabies does not pass our pathway. We'll be able to catch it.
Yes.
We have this one from Dakua Dukofi. He's also thanking you for your presentation, but he's craving and the indulgence of GSD if there'll be more of such CPDs soon from your association.
Thank you very much. And as Dr. Martin Ejay said from the beginning, we have, this is the first post-COVID and many will follow soon. And so I think I speak for the whole society on that.
Okay, thanks for the promise.
May I come in here, Bridget?
Yes, please.
Yes, please.
Yeah, we have one slated for November.
Yes.
Okay.
This year, yeah.
Okay. Thank you so much. It sounds promising. And this from Victoria Mafua Aduma Frifa. She's also thanking you, Bridget, and say, please, for those patients in whom ivermectin is contraindicated, like say in pregnant women, is there any other oral medications that can be used?
I think that let's not be fixated on oral medications. The topicals work as well or as good as the oral. And so if it is topical, let's use the topical. And it's important to let the patient know that the itch might last or might outlast the infestation. So the fact that they are still itching doesn't mean that the infestation is active. So if ivermectin is contraindicated, any of the topicals, if the person can afford 5% permethrin cream, or if the person cannot, good old benzyl benzoate in the age-appropriate concentration. Thank you.
All right. Thank you, Dr. Bridget. This is from Frank Owusu-Ifa. He's asking, should close relatives of people infested with scabies also be treated, whether they are showing symptoms or not? I guess this is what he was asking.
Yes. So they should be treated. Like I said, different immune response. Infestation might take 4 to 6 or 8 weeks to for the person to show symptoms, and it would be very inappropriate or sad to treat the index patient and then let the contact now start infecting the rest of the household. So it is important to treat everybody. So for me, what I do is I treat the index with ivermectin and then the contacts with topicals. But my research build up to this presentation, I find that I can actually just treat everybody with ivermectin and it's easier for everybody. So as Dr. Martin said, we are all still learning.
Okay, thank you for being able to absorb all these questions. We have just a few more. Solomon Azu says he's thanking you for the presentation, but he's just want to find out. Solomon doesn't want to miss the mark. He said, can one join benzyl benzoate lotion and sulfur at the same time? Can you use the two to treat scabies at the same time? Benzyl benzoate lotion and sulfur.
So with the benzyl benzoate, you use, you finish on the third night and then you have a break to repeat. So in between, you can decide to do the sulfur if you want to add on, but you shouldn't do it during the treatment period when the benzyl benzoate is supposed to dry on the skin and then kill the mites. Otherwise, you might be diluting the potency of the medication.
Okay, good. Then this from Desmond Alote. He's asking, is Clotameton cream curative? Clotameton cream, is it curative for scabies?
It's also mentioned in the literature, but by the WHO standards, these were the medications recommended.
Oh, okay.
Yeah,
And
but it also has a high efficacy and can be used.
All right, we take this one from Francis Silfi. He's asking, is there a possibility of treatment failure with any of these agents mentioned? And if there is, how are you going to determine that indeed you have treatment failure?
Okay, yes, there can be treatment failure, and this can only be determined after some weeks because, as we said, the H would outlive the infestation. And so if after about 4 weeks of treatment, you still see active lesions, then it's an indication that your treatment might either have failed or there is a family member or a contact in school or at work that the person is in close contact with that is still infecting the person. So you have to decide whether it's a treatment failure or it's a reinfestation. So this is what I can say. I don't know whether colleagues would want to add on.
Yeah, may I quickly come in and add on something? Yeah, what might appear to be a treatment failure is usually the eggs that were missed in the initial treatment, which you hatch on later, and then it might appear as if the one is suffering from a reinfection. So that might appear as if a treatment failure. So it's important that one should endeavor to repeat after the initial treatment.
Yeah.
So that the eggs that you miss that will hatch later will be caught in the treatment and dealt with.
Okay.
Thank you.
All right. Thanks,
Thank
Dr.
you.
Flu, for the contribution. We take this one from Dr. Gold Ohuchuku. She's asking, is the management of crisis scabies different from what we've heard so far?
No, yes and no. Yes, no in terms of same drugs, but yes in terms of more frequency. So in crusted scabies, instead of repeating once after 1 week, you would want to repeat maybe 2 times after that. So more of weekly for maybe 3 weeks before you stop the management. And also fomites management is very, very crucial in crusted scabies. So if you have a vacuum cleaner, you make sure you vacuum everywhere. You make sure you clean with strong detergents and all that. So yes and no, same treatment modalities, but more frequency and then more care of fomites.
All right, thank you. We take this one from Bright Boglo. Bright is thanking you for the presentation and has this question that if you have a household where a member is affected, do they need to come to your clinic for assessment before you manage them? Or you can just go ahead and just prescribe the medication, take it home, give it to your people there, and then let them use it. And then secondly, he's asking about Urax cream. How effective is it against scabies in your experience?
Okay, so contact management in the public sector, I would usually ask for contacts to be brought. Private sector, sometimes it's a bit much, and so it would not lead to appropriate treatment, because if you treat the index case and the contacts are still there, then you are not curbing the menace of scabies. So as I said, it's more of the topicals for the contacts, so told what to go and do. But then if there are people who have active disease, then I would say they should come over for assessment and treatment, because for all you know, there could be secondary bacterial infection, which the lay person might not be able to identify. And then coming to Urax, yes, it has some degree of activity against the mite, but from the literature, it is not, what's the word to use? It is not licensed for the treatment of scabies. And I don't, in my experience, I don't use Urax. I don't know whether colleagues use and would want to comment.
Okay, thank you. We have this from Francis Silfi. Francis is still asking, how do we manage contacts? I think that has been mentioned, but contacts, how do we manage them? That has been mentioned. No?
I think we just, maybe the question came before I answered the previous
I guess so.
question. Yeah.
I guess so. And then this from Esther Fojo, can topical steroid creams also be used as part of the management of scabies?
So when the inflammation is very strong, when you see very erythematous lesions, yes, but then you have to be sure that there are no secondary bacterial infection. Even oral steroids, I didn't want to mention that here, but can be used in very severe cases. But you would want to stick to something. So when you give the your oral antihistamines, you may want to add topical antihistamines to it, so they see that they are doing something to the skin, and that should help.
Great. This from Do Klu. Do is asking, is there any room for tetmosol soap in the treatment?
Not that I know of.
Okay. This from Evans.
Dr. J.
Yeah.
Can some of the questions be taken in the answered in the chat column, or we still have time for my presentation?
Actually, it's time for the drug presentation.
Mm.
So I think we will do as you have just suggested, so that they will be directed to you and then you can answer, because the questions keep coming and I think we might run over time.
Okay.
So all the others, please, that will be responded to in due course, but let's just follow the program. So at this time,
Thank you very much.
yeah, thank you so much, Dr. Bridget Gogo Dako. Yeah, so as per our program, we're going to have a very short drug presentation by Bioderma Pharmaceuticals. So if they are ready, Bioderma Pharmaceuticals, are you there? Great.
Hello.
Hello.
Hello, go ahead.
Yeah.
Okay, thank you. So my name is Iman and I am the area manager for Bioderma in Sub-Saharan Africa. I want to start by saying that we are not a pharmaceutical company. We are a laboratory that makes dermocosmetics. So our at the heart of our brand is to accompany dermatological treatments, medicated treatments, but we do dermocosmetics. So today I will share with you talk about our Pigment Bio range, which is our range for hyperpigmented skin. So the let me check. It's not okay. It's working now. So the first thing is to define, I would say, what hyperpigmentation is. So hyperpigmentation comes from UVB and UVA rays that are primarily responsible for the pigmentation disorders. They stimulate pigmentation via specific biological mechanisms. We have the UVA rays that trigger oxidative stress, which is responsible for immediate pigmentation. Then immediate pigmentation is due to the oxidation of the melanin already present in the skin. UVB rays, however, act strongly to induce melanogenesis, where they stimulate the proliferation of melanocytes, the production of melanin, as well as its transfer to the upper layers of the epidermis. They are responsible for what we call delayed pigmentation. There are a few manifestations, I would say, of hyperpigmentation. We have, of course, melasma, we have lentigo, post-inflammatory hyperpigmentation, which is very prevalent in darker skins, ephthalites or freckles, and also hyperpigmentation in areas in areas subject to friction. So when it comes to hyperpigmentation, there are, as I said, dermatological solutions. So when you go to a dermatologist, which is usually the key resource to treat hyperpigmentation, there is a variety of solutions that are offered. The most well-known and the star treatment is Kligman's Trio. We also have hydroquinone as a monotherapy, corticosteroids, retinoic acid, azelaic acid, pills, energy-based treatments such as pulse, light, and lasers, and also cryotherapy. When we are going to focus on Kligman's Trio, which is, as I said, the star treatment for hyperpigmentation. In Kligman's Trio, we have 3 ingredients with 3 actions. The first one is hydrocortisone, which is going to help to decrease melanin quantity in the epidermis. The second one is hydrocortisone, which is going to be, has an anti-inflammatory action. And then we have retinoic acid that's going to help to accelerate cell renewal. We know that when it comes to this gold standard treatment, which is Kligman's Trio, the preparation must be renewed after 1 month. It is applied twice a day for at least 8 to 12 weeks. Subsequent maintenance treatment is required. It can also only be used 4 months maximum per year because it's very harsh on the skin, and it must be complemented by the use of sun protection product and cosmetic depigmentation product to limit recurrence, often over a minimum period of 3 months without treatment. Compliance with special conditions of use is important for hydroquinone. There has to be use of low doses as first-line therapy, apply small quantities of product onto small areas, avoid applying too often, limit the duration of use, and also avoid, and that's very important, sun exposure. Depigmentation only becomes apparent 3 to 5 weeks after the start of treatment, and the maximum effect occurs after 5 to 7 weeks of treatment. If no skin lightening occurs after 2 months, it is unlikely that continuing the treatment will be beneficial. After achieving the desired pigmentation, a single daily application is sufficient to maintain the effect, and a reduction in the concentration of active ingredient may be envisaged. So when we conducted our research, when we discussed with dermatologists regarding Kligman's trio, what they told us that they needed was first something that was going to accompany their treatment and prevent the side effects of said treatment, something that could work as a relay of the treatment to maintain the efficacy. So during these periods while the treatment cannot be applied, so the recovery periods, and also something that was going to optimize skin recovery between treatments. On the side of the patient or the consumer, what they want is something that will provide immediate and long-lasting efficacy on dark spots, brightness and even skin tone, and also respect the sensitivity of their skin. So at Bioderma, we have worked on an innovation and a solution to hyperpigmentation. It is a comprehensive care program as a follow-up to treatments to maintain their efficacy. To support patients suffering from pigmentation disorders, we created a dermatological program that helps to correct the complexion with lasting results. These high tolerance skincare products are used as a follow-up dermatological treatment, such as Kligman's trio, and also help to prevent relapses during treatment discontinuation phases to prolong their positive effects. And so our solution is going to prevent and correct the skin hyperpigmentation, help find the original radiance of the skin. It's going to work as a relay of depigmenting treatments and optimize also the skin barrier altered by treatments. With this solution, we have dark spot efficacy with our patent that is called the Lumi-Reveal technology, which is inspired by Kligman's trio, and we also have a skin barrier support all year long. Here are the details of our patent. Our patent is called the Lumi-Reveal technology. As I mentioned earlier, it is inspired by Kligman's trio. So we have ingredients that work like Kligman's trio, but they are different ingredients. For example, we have andrographolide and lisinazolate that reduce melanogenesis, so they are going to work like hydroquinone. We have glabridine that also reduces melanogenesis and provides anti-inflammatory activity, so it's going to work like hydrocortisone. And we have something called epiderm active that is going to work like retinoic acid to accelerate the cell renewal. So here you can see the equivalence. Inspired by the mechanism of action of leading dermatological treatments, Bioderma developed a new range of medicated care products featuring the Lumi-Reveal technology. This technology provides a mode of action inspired by Kligman's trio without associated cutaneous side effects for a well-tolerated and long-lasting treatment. So as far as efficacy, we have done a lot of studies, and at the end of the presentation, I actually have some results to share for our latest clinical trial that we have conducted in South Africa for phototypes 5 and 6, because this is a question that we got a lot when presenting this range. We know that it works well, it's very effective when we see the weight of sales, so we know it works well from dermatologists to patients. We get very positive feedback, but we needed to also provide proof of efficacy on really darker skins. So on dark spot efficacy with the Lumi Reveal technology, here you have the depigmentation action. So the tyrosinase is a key enzyme involved in melanogenesis mechanism, and the Lumi Reveal technology has a big depigmenting action linked to the inhibition of this enzyme, as demonstrated in the test tube assessment carried at our laboratories, compared with the dermatologist reference depigmenting molecule, which is hydroquinone. So you can see with 2% hydroquinone, 4% hydroquinone, and the result of Lumi Reveal technology. When it comes to anti-inflammatory action, we also can see the efficacy of glabridine compared to indomethacin, in a study conducted in Belgium in January 2017. Then for the cell renewal action, we did a comparison between the use of epidermactive and an untreated area, and we see that the efficacy after 14 days is higher in the area treated with the epidermactive compared to the untreated area. Lastly, for skin barrier support, we added 3 vitamins which bring additional benefits to the skin: vitamin C, vitamin E, and vitamin PP or niacinamide. Vitamin C and E both protect the skin against oxidation and counteract the damaging effects of UV and pollution on collagen and elastin. Thus, vitamin C and E have a key role in the prevention of premature skin aging. And vitamin PP promotes lipid synthesis in intercorneocyte cement, so ceramides, fatty acids, and cholesterol. And this cement ensures skin cells cohesion. It plays a significant role in strengthening the cutaneous barrier and cutaneous hydration. Thus, the skin recovers its resistance after the use of treatment prescribed by the doctor. So again, we are working as a relay in combination or as a relay of the dermatological treatment. So this is our range. We have a full range that covers all your needs, from hygiene to daytime use to nighttime use, and even for body care use. I will take time to talk about the key product in this range, the star product in this range, which is the Pigment Bio C concentrate. It is what we consider your prescription partner. It's a brightening pigmentation corrector made of fresh vitamin C. I will discuss that in more details later. So the C concentrate combines the Lumi Reveal technology with high concentration of salicylic acid, glycolic acid, and fresh vitamin C. So we have 2% salicylic acid, 8% glycolic acid, and 2% fresh vitamin C. We talk about fresh vitamin C because it is stored separately in a special canister, protecting it from air and light. You activate that vitamin C at first use, so we protect the efficacy. Then we have optimized quality and stabilization of the vitamin C. While Lumi Reveal technology and fresh vitamin C control melanin production, salicylic acid and glycolic acids will help to boost cell renewal, giving a peeling-like effect for a brighter and smoother skin. So on the topic of the vitamin C, this is a key aspect of our product compared to any other product on the market today. We have a fresh vitamin C that comes in a powder. this is not the classic ascorbic acid that everyone knows that we use. We chose a more effective derivative that's called ascorbyl glucoside. It has been proven thanks to in vitro study that ascorbyl glucoside is 6 times more effective on the melanin brightening effect after 2 days than ascorbic acid. It has also been proven that ascorbyl glucoside is more stable over time and stays longer in the skin compared to ascorbic acid, and it can deliver its brightening properties for longer. Thanks to that innovative packaging, so the special canister that I mentioned, we can keep and isolate the vitamin C powder in a separate area, and it's only going to be activated at first use. Once the vitamin C is released in the formula, it oxidizes much slower. And after 8 days, we can see that it's still present in the skin while ascorbic acid has disappeared. So we have something more stable and with a longer efficacy. So this is how you can use how the C concentrate is your prescription partner. As a relay of your treatment to maintain efficacy, 3 months until starting the next dermatological treatment, or as a monotherapy, 1 up to 3 months. And it's a nighttime use only. So for daytime, we also have a complementary product that is called the Daily Care, which is a brightening care product with SPF 50. So we have a 2-in-1 product that is going to make it easier for the patient to really observe the use of their sun protection. And these are the results of the study we conducted in South Africa. So it was end of last year, 30 subjects, only phototypes 5 and 6. And we know the results were that dark spots were reduced by 45% in size, by 29%, and in intensity by 42%. So again, we know this product works, and we know it has the efficacy even in darker skins. So this is the end of my presentation. Just let me know if you have questions. I also put at the bottom the contact of our team in Ghana. So you have Ernestina and Isaac that will be able to, that you can contact if you have any other questions.
All right, great. Thank you so much, Bioderma Dermatological Laboratory, for this presentation. So, as we've been doing, we're almost getting to the end of our lectures. If anybody has any question, please, for the speaker, you can do so now.
I have one question.
Great.
So I'm looking at the routine that you advised on, and at night you said pigment bio night renewer. I haven't seen that in Ghana. Do we have it?
So I think you do have it.
The pigment bio night renewer. It's the first time I hear about it. Do we have it in Ghana?
Yes, I'm sure it has. So it's in the dark. So let me just put the contact in. You can contact us. We will be able to let you know where you find it.
All right. Yeah. Any more question?
I can see there are questions about the cost. What do the products cost?
In Ghana, I don't have cost on the internet. Just the area. So for us, the easiest way to get the cost, you contact the team in Ghana, so the number put on.
Looks like the voice is a bit shaky at my end. I don't know if the others were able to hear.
No, even before we couldn't hear anymore.
Yeah, it looks like.
Can you hear now? Can you hear now?
Yeah, now it's better.
Okay, I was saying that because I'm not actually I'm not in the team for Ghana. I'm the area manager, so I work for the Bioderma brand. The easiest way for you to get the actual cost is to contact the people whose contact I put there, because they are in Ghana. They are the team in Ghana, so they will be able to advise you and inform you on the cost of the product and the availability.
Great, thank you. Besides the question about cost, does anyone have another question before we move to our last speaker? All right, it looks like we don't have any more questions. Great,
right.
so thank you so much once again, Bioderma. Now we come to our last speaker, who is going to talk about chicken pox versus monkey pox. It looks like during my introductory speech, there was a slip of tongue. There was a mention about smallpox. Just pardon me. So we have Dr. Emmanuel Kecha, who is going to take us through the similarities and the differences between chicken pox and monkey pox. Dr. Kecha, please, are you there?
Yeah, yes,
All right.
I'm around.
Okay, great. So your audience.
Let me just share my. Okay, so good evening once again. And I'll be looking at chicken pox and monkey pox, their similarities and differences. So the outline will be as follows. We'll have a brief talk on chicken pox. We'll also look at monkey pox, and then we can tell the differences and similarities between them. Okay, so in terms of chicken pox, it's also called varicella, and it's caused by the varicella zoster virus. This virus is a member of the herpes virus family and has a linear double-stranded DNA. Humans are the only host of this disease. So it's transmitted either through contact with aerosolized droplets from nasopharyngeal secretions of an infected individual, or by direct contact with the vesical fluid from an infected person. So following entry of the virus, it will replicate in the original lymph nodes and then disseminate first to the reticuloendothelial system, and then secondly to the skin. In terms of the incubation period, it averages about 14 to 16 days, but it can range from 10 to 21 days. And a person or a patient is typically infectious 1 to 2 days before the exanthem appears until the last crop of the vesicles have crusted. Between 2 to 3 days. And then the patients within this period will be experiencing symptoms such as fever, chills, headache, backache, malaise. Some people may even have sore throat and dry cough. And after this period, the rash starts to appear. So in terms of chickenpox, the rash would go through different stages. So first you have the macules, which then progress to the papules, and then vesicles will go to the pustules and then would crust. So it will first start from here until it crusts. And in chickenpox, in one area of the skin, you are likely to see all of these lesions at different stages. It usually begins on the face and scalp and spreads to the trunk with a relative sparing of the extremities. So in chickenpox, we say the distribution is centripetal. So you have a lot on the trunk and then few on the extremities. We'll look at monkeypox and then we'll be able to determine the differences when it comes to the distribution. Usually, new vesicle formation stops within 4 days, and most lesions would have crusted by day 6 in a normal host. So this is a picture showing one area of the skin, and you can see that there are different skin lesions. They look different. If you look closely, you can see that this appears crusted. You can see a vesicle there, and then you can see papules which are developing. So one characteristic about chickenpox is that when you look at one area of the skin, you can see different types of lesions, as we've described them: macules, papules, vesicles, pustules, and then crusting. When you look at the right side, so you can also appreciate that. So you can see these vesicles there. You can see a papule there, and you can see this area of crusting. So once you see this in an area of skin, you are likely dealing with chickenpox. I mean, in the right clinical scenario. So apart from the skin, other places can also be involved, which include the mouth, the nose, the pharynx, larynx, and trachea. And at the mucosal surfaces, the vesicles rupture. So you may be unlikely to see them. Rather, what you see are these ulcers, at those sites. Other symptoms that the patients may present with include pruritus, and usually it's present until all the lesions have crusted, be delayed or absent. So you may be unlikely. So that's just with complications and it can progress. In adults, they would have pneumonia. And in pregnancy, there can be a threat to both the mother and then the fetus. So complications can also occur in patients who are immunocompromised, and usually they are very severe. So in terms of defining patients who are immunocompromised, we have patients who fall within this category. So either you have HIV infection, you're using steroids, you're on immunosuppressive therapy, or malignancy. And in these patients, they have severe disease, even involving some of the visceral organs. The liver is not spared, like the brain is also not spared, and then you can also have hemorrhagic complications. So the diagnosis of chickenpox can be made a prodrome followed by the development of the lesion. Difficult, or there may be other differential diagnosis using either scraping scraps, which include isolation and culture of the virus, enzyme immunoassay, and even ELISA. Antihistamines, antipyretics. But there are particular indications of antiviral therapy all the way down to force count. Would include individuals who present or those who are even at high risk of complications. And these will include adults, pregnant women, immunocompromised hosts, and unvaccinated adolescents. Now, in terms of prophylaxis, pre-exposure vaccination can be done. So in certain countries, as part of their immunization schedule, they are immunized with the varicella vaccine. But The vaccines are also available through the childhood vaccination agents which can be used. So you have the varicella, and that should be administered as soon as possible after exposure and within 10 days. And then for those who are unable to get either the vaccine or the immune globulin, antiviral therapy can be administered for 7 days, beginning 7 days after exposure. So all these are available for patients who present in the particular scenarios. Okay. Now we'll also look at monkeypox briefly before we go on to the similarities and then the differences. So monkeypox is caused by the monkeypox virus. This virus is a member of the orthopoxviridae group. It's DNA. And so some of the primates are apes, gorillas, chimpanzees, orangutans. And then some of these non-primate animals would include rabbits, mice, guinea pigs, rats, squirrels, and then the giant anteaters. In terms of the transmission, it can occur either from animal to human or from human to human. With respect to the animal to human transmission, usually if there's contact with infected body fluids of an infected animal or through a bite or scratch of an infected animal. And then for the human to human transmission, it can either be direct contact. Now, the direct contact person, which comes direct contact, you have fomites, which include clothing and linen, which are contaminated. And respect to respiratory secretions, usually there has to be a prolonged face-to-face contact before getting the being able to transmit the virus. The transmission through vertical means leading to congenital monkeypox is actually not known. There, however, has been case reports of percutaneous inoculation. And now spread through other body fluids, such as semen, urine, feces, is actually not known. Okay, so after the virus comes into contact with the individual or the patient, it would multiply at the local site of injury and then go to the regional lymph node. And then it will disseminate to distant sites. And the patients with monkeypox is generally infective from the onset of the clinical manifestations until all the lesions have scabbed over and reepithelialization has occurred. So within this period, the infection to someone. The incubation 13 days, but it can range. And after this incubation, symptoms of high fever, chills, malaise, headache, myalgia, back pain, and also presents with diarrhea or even abdominal pain. And these usually last for 1 to 5 days. And it can either occur before or even occur after the rash. So in the evolution of the rash after the prodromal period, It also starts with macules, which would then progress to papules. Then they don't actually contain fluid, rather they contain solid material. And then they umbilicate and then crust. And the distribution of these lesions on the face and extremities with relative sparing of the trunk. So this is what we refer to as the centrifugal distribution. And the lesions typically begin to develop simultaneously and then evolve together on any given part of the body. So as compared to the chickenpox, where you had different lesions at any given part of the body, initial lesions seen in monkeypox were thought to evolve together at any given part of the body. So in this picture, we can see that, so this is showing the face, okay? And we can see that all the lesions here look the same as compared to the picture that we saw with the chickenpox, where we could see different looking lesions. So this is one of the ways we can try and make a distinction. And then the other thing is to look out for the umbilication. So if you look in the palm, you realize that the lesions are there, but there seems to be a central dimpling in the lesions. You realize that they all look the same. And then you have the central dimpling. So that's what we call the umbilication. So once you have these pseudopustules, we've seen that these pseudopustules, some of them have crusted, but they all look the same actually. But when you look here, you can actually appreciate the umbilication there. So at any given part of the body, they all sort of move together. If you go to another part, you may see another group of lesions, but they would all move together in the progression. Now, something happened in the 2022 outbreak where there were other manifestations which were not similar to what we've already described. In these patients, they didn't have any systemic illness. And they frequently presented with lesions located in the anogenital and then perioral areas alone. Some of them also had small number of lesions on the trunk or epidural parts of the body, and not all the lesions were in the same stage of development. Because as we said before, typically for monkeypox, you expect that all of them will be at the same stage. But in the 2022 outbreak, it changed. So that manifestation, the genital perioral, picture. In patients with advanced HIV, they may have severe disease leading to even necrotizing lesions. So if you look at this picture, you realize that you're seeing a similar thing to what we described for the chickenpox, that there were different lesions actually. So if you look at this, you can see what looks like a pustule, you can see some crusted areas there, and then you can see what looks like a vesicle. So in that creates a bit of confusion if you want to use that mpox. So it's just for us to bear in mind that before the 2022 outbreak and then in patients. Okay, sorry, I think my network tripped a bit. Is my slide visible?
Yes, but that's the very beginning. Okay.
Yes.
Okay. So please, where did I get to before the network went off?
Move.
Have I spoken about? Okay.
Yeah, you are here. Mhm.
Yeah. Sorry. Hello.
Hello, Keche. We can hear you and see your slide.
Okay, all right. Then I'll just move on. Okay, so the patient can also present with other complications such as neurological, ocular, and even have proctitis or tonsillitis. The diagnosis of monkeypox usually clinical. However, laboratory diagnosis can also help where there are, suspicions of a different diagnosis. Just as we said for the post-2022 period, some of the lesions appeared similar to chickenpox. So where there's a doubt of whether what you are dealing with is chickenpox or monkeypox, you can actually do some of these laboratory investigations, which include PCR, viral isolation and culture, electron microscopy, or even a skin biopsy. So most patients, would have a self-limited disease, and the symptoms may last for about 2 to 4 weeks. However, in severe disease, this, severity of the symptoms or the signs may be seen in patients with underlying immunodeficient applications. Mortality is generally to occur mainly in children and usually secondary to bacterial superimposition and then GI and pulmonary complications. So the management is usually supportive and with antiviral therapy prophylaxis under certain circumstances. So some of the antiviral agents which have been found to help include tecovirimat, trifluridine, and then cidofovir and brincidofovir. And these are actually given in particular circumstances. So those with severe disease, such as those with hemorrhagic disease, confluent lesions, and encephalitis, and also those at risk for severe disease, which include patients with a history or presence of atopic dermatitis, compromised patients than 8 years of age, patients who are pregnant, such as the mouth, the pharynx, and the genital area, and also patients with infection of the eye. Prophylaxis, it will be given for selected patients with high risk of monkeypox infection due to either behavioral or occupational risk factors. So those who work in labs where they handle the viruses, would be some people to give the pre-exposure prophylaxis. And then the post-exposure vaccination is usually recommended based on the level of risk, and usually is given within 4 to 14 days of direct exposure, and also recommended for pregnant women. However, patients with severe immune deficiency in T cell. So now we'll try and see whether we can tease this. Okay, so by way of the cause, we know they are all viruses. That is what is common to both of them. However, the type of those with the monkeypox virus, there's a type of 10 to 21 days, while the monkeypox it lasts for about 4 to 21 days. We'll see that at least 3 weeks, maybe should be or maybe shorter. That's at the lower. Now, in terms of the transmission for chickens, can go both ways, either from human to human. Is common for monkeypox is 1 to 5 days, but the symptoms are quite similar. Fever, chills, headache, are common to both of them. It can be made clinically, as we've already said. However, being considered, other as well as a biopsy can be done. Treatments usually symptomatic, for antiviral therapy and prophylaxis for both of the diseases. Now, mortality in chickenpox is quite rare. However, in monkeypox is, about 1 to 10%. And now, in terms of the rash characteristic, the progression of the lesions is similar at a point, and then macules, then progress to papules, vesicles, pustules, and crust. You have vesicles before the crust. So, sorry, this is supposed to be monkeypox. No, that's a typo. So the umbilication is actually not seen in chickenpox. However, it's present in monkeypox. And then in the distribution, you have a centripetal distribution in chickenpox. However, a centrifugal distribution in monkeypox. And then, as we said earlier, the lesions are in various stages of development simultaneously for chickenpox. However, when it comes to monkeypox, the lesions are similar, but could be in various stages. As we said, in the 2022 outbreak, there was a difference in the way the lesions were. So this will be about the last slide, talking about how the distribution is, so that pictorially we can appreciate the difference. So there's a centripetal distribution where you have a lot more lesions on the trunk and face as compared to the extremities. You realize that the trunk is actually spared. Okay, so this will be my last slide, and we can have maybe comments from there.
All right.
Thank you.
Okay. We appreciate Dr. Emmanuel Keche so far on the way he has enlightened us on the differences and the similarities between chickenpox and monkeypox. I was wondering where he has been all this while, because I have to confess, just like I did mention, and I was echoed by Dr. Bridget Gogo, during the peak of the COVID pandemic, I had a child that was referred to my clinic with monkeypox, and I had to fall on a colleague in Netherlands who was able to help with the clinical diagnosis, and KCCR had to come in with a PCR, which did confirm that it was monkeypox, but for political reasons, we're not even allowed to even publish it so that it will not put fear into the public. Because of time, we want to do it this way to save us some minutes. If you have any question for Dr. Emmanuel Keche on the last presentation, as well as to any of the speakers, we will recommend that you will pass your questions to the Q&A box or section, and then these panelists will try to write the answers to you so as to save us some time. So we are bringing our meeting to an end. And before I say anything, I just want to remind us once again, as was requested and was answered, that Ghana Society of Dermatology is planning to bring us a fresh set of topics of interest come November this year. So pin it down somewhere on your in your diary, so that as soon as you hear of the flyout, you'll be able to join us in November, and we hope we'll have another enjoyable encounter. So on this note, before we hear the closing remarks from the president of the society, I want to thank all participants for this encounter. And I know we've all learned a lot from these three speakers. The first had to do with diffuse systemic scleroderma. And now, if we come across any patient presenting with melanin loss, we'll not jump onto vitiligo. At least remembering this salt and pepper presentation where you have loss of pigment, but then you have preserved pigment, which corresponds to the perifollicular osteum. You should click the bell that we are dealing with systemic sclerosis. And then the routine questions will come. Can you open your mouth? And the rest, as we heard from Dr. Jeanette. And then scabies, I know now we are all specialists. I wonder if I'm going to have any referral to my clinic from this time, because all of us are now experts at picking scabies from our patients. And then chickenpox and monkeypox, nobody can deceive us. At least we know the distribution. If we didn't remember anything, the central implication, we have that one in mind. So on this note, I want to invite the closing remark from on behalf of the president, and perhaps from Dr. Janet Ayiboy, if Janet is still there. Janet, are you there?
Yes, I'm there. I'm
Oh, thank you that you are alive. Okay. Okay.
So in the name of the president, I will take this opportunity to thank you all for participating in DCPD. We are all happy that we were able to provide DCPD today. And as promised, we will present another one in November. I hope that we can all agree that today's topics have taken away some of the mysteries that many non-dermatologists seem to perceive when it comes to the skin. And you are going to see, with more CPDs to come, more of the mysteries will disappear. Thank you to all presenters, and let us all have a wonderful evening. Goodbye.
Thank you, the Vice President of the Ghana Society of Dermatology, for this closing remark. So just as we began with a prayer, we want to call on our dear Dr. Juliet Opoku to take us through a closing prayer and to usher us into the next weekend, free from stress. Dr. Juliet.
Yes,
are you there?
Dr. J, I'm here.
Yes, dear. Can you take us through the closing prayer?
Shall we pray? Dear Lord and Master, we thank you for this opportunity given us to have this deliberation this evening. We pray that subsequent ones will also be successful. And we ask that you shall give us a blessed night and a good weekend. In Jesus' name, amen.
Amen. So I wish you all a stress-free weekend. And we hope to meet another time. Bye to all. Okay.
Bye.
Bye.
Thank you.